Hi everyone, it's Professor Costa, and today we're going to be covering patient-centered care. And we're going to be looking at things like case management, discharge planning, patient rehabilitation, and community resources. And that, we need to be thinking about our patients in the community and preparing them for discharge. Even if you're in an acute care hospital, you should always be mindful of where your patient's going to end up after their stay. All right, so we have a nice case study. We have Mrs. M, an 80-year-old who lives independently at home, and she fell while taking her daily walk at the park with her dog. Her past medical history includes hypertension, for which she takes Hyzar, which is losartan and hydrochlorothiazide, daily. Upon arrival to the emergency room, it is determined that Mrs. M has an intracapsular fracture of her right hip, which will require replacement surgery. So some of you might be that it really isn't the point, but we're looking at the neck of the hip, and not every patient needs a hip replacement. If it depends on how complicated a fracture it is. And for this case study, we're going to say Mrs. M requires a total hip replacement. All right, so Mrs. M's recovery really will take a village, right? So it's her family, her friends, the primary RNs and ancillary staff in her acute care hospital, her physician. We sometimes, you'll also see them listed as a licensed independent provider, an LIP. And then the RN case manager, which is a very important role at any facility. And they work with social work, physical therapy, occupational therapy, nutritionists, spiritual support, many, many, many others. Remember, this is a big deal surgery. This isn't like a little teeny weeny, having a mole removed. So both the ball and the head of the femur are going to be replaced. It's a total hip replacement. And think of things that happen when you have this kind of surgery. She's going to have general anesthesia at the age of 80. So that's no small feat. During surgery, she's going to have a Foley placed. Most likely these things get removed immediately following surgery. But anytime we introduce a foreign body into that bladder, we're risking a urinary tract infection. Surgical site infection. So she has a huge risk for a postoperative infection due to her age. Risk for bleeding. Just from having surgery. And the femur is, very vascular, so we have to worry about bleeding for her. Immobility. So anytime that she's not walking around, and that includes probably, she fell in the morning, they're not going to, do surgery immediately. Sometimes that requires a stay of a day or two, sometimes under traction. So patients are going to be immobile for, maybe hours to days. And we're going to increase her risk for all of those immobility complications, right? So DVT, pneumonia, all of that. She'll probably be receiving opioids for pain management. This is a broken bone. It's painful. She's going to have surgery to fix it. So we're at risk for respiratory depression and constipation. Also, this lady is 80 years old, and older adults take a little longer to recover from general anesthesia. And even patients who don't have any dementia may be, they're at risk for being just a little loopy for a little longer. We have people who are completely normal at home, take care of all their own affairs. They have general anesthesia, and we may actually have to have a sitter with them for a day or two. All right. So there's a lot of risk. This isn't a routine surgery. She fell, and they're also going to have to do things like investigate. Did she trip over the dog? Did she have a syncopal episode? So she'd have other workups too. She may have probably I'm assuming, but probably an EKG. They may even rule out things like stroke before they do her surgery. So this is a huge deal. This isn't like a little surgery. And this person, Mrs. M, is going to need a lot of help to get back to her independent state. All right. So while she's in the short-term acute care hospital, so let's say she got rushed to Miriam following her fall in the park. Okay, that's a short-term acute care hospital. The big thing that we worry about whenever someone enters the hospital is safety, patient safety. Yes, we want to fix what's wrong with them, but we don't want to cause harm just from them being in the hospital. And there are multiple safeguards in place. So one of them is the Institute of Medicine, and they have to err as human. The Joint Commission, which you've all heard about, the National Patient Safety Goals. The Institute for Healthcare Improvement had their 100,000 Lives campaign. The Institute for Healthcare Improvement also helped with development and recommendation for rapid response teams. Those are sometimes called medical emergency teams, or METs, in other hospitals. But that was part of the Institute for Healthcare Improvement, and that was so significant that the Joint Commission actually said, well, you've got to have some kind of backup for your nursing staff in the hospital. And that all came from the Institute for Healthcare Improvement. All right, so that's their 100,000 Lives campaign. So, they did all types of studies, and they realized that rapid response teams save lives. They really do. They help prevent out of ICU codes. So if someone's showing early signs, and I mean early signs, hours before any potential life-threatening event, if we intervene at the first sign of distress, then we can prevent that patient from coding. Before rapid response teams, the primary nurse on a med-surg floor, their patients started showing signs of respiratory, like a little extra oxygen, or that would be under the management of the nurse on the floor. Now, an indicator for calling rapid response is something as simple as nurse concern. You can't quite put your finger on it, but you know something's wrong. You can call a rapid response. Study after study after study showed that rapid response teams save lives. Okay, and that's part of the campaign planks. Delivery of reliable evidence-based care for acute myocardial infarction. Medication reconciliation, huge. How many people before all of these things were implemented were missing an important home medication just because it wasn't the reason they came into the hospital? Things can be used to be overlooked. Their daily thyroid medication, or their daily medication that they were using for treatment of a chronic condition like myasthenia gravis, might have been missed if it weren't for the implementation of standardized medication reconciliation. Prevention of central line infections, huge. Prevention of surgical site infections, and prevention of ventilator-associated pneumonia. And we already talked about that in oxygenation, preventing VAP, ZAP, VAP. These are all things that came about from evidence-based research, doing studies, looking at indicators. And now we have a lot of things in place. So, some core competencies for health professionals. One of them from the Institute of Medicine is to err as human. And we found out that if people felt more comfortable reporting errors, we could figure out what caused the problem and fix it. So there was always like, oh, don't say anything because you don't want to get in trouble. Now, errors happen. Some things are predictable, some things are preventable. So it's usually a multifactorial miscommunication, or if it's a medication problem, maybe something was mislabeled, or the physician wasn't clear. So it isn't always just one person's fault. Sometimes it is, but being able to report a problem makes us better able to fix it. So other things that they have is providing patient-centered care, having the patient be involved in planning their own care. Collaborate with interdisciplinary healthcare members. So if we're worried about a patient's nutrition status, then that nutritionist should definitely be involved in managing that patient. Implementing evidence-based practice. And this is a continual process. Things change, right? So we're not just going to go by evidence we collected 15 years ago. We're going to continually reevaluate our practices and use evidence. Does this truly improve patient outcomes, or does it truly improve the patient experience or education or whatever it is? And then we're going to use informatics. Informatics is an important partner in this now because we can put algorithms into charting systems where they can pick up trends and look at long-term effects. So informatics is really important. I know in Cerner, for instance, they for Care New England, they added a sepsis trigger. So if a patient is showing early signs of sepsis, the informatics system will automatically alert the nurse. Maybe something you weren't quite was on the back burner, such as a laboratory value, and now they have an increased respiratory rate. Well, that triggers the sepsis protocol and saying you need to address this patient is at risk for sepsis. The other big player in this is the quality and safety education for nurses, or QSIN. So those are validated Institute of Medicine competencies, and they added safety big time as a separate competency. So they were KSAs, so knowledge, skills, attitudes. And these may look pretty familiar to you from your CCRI core pillars. So patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. You can look these up on QSIN.org, and these are now called the QSIN Initiative. All right, so again, these are our own CCRI's core organizing concepts, and they're derived from QSIN. We didn't just decide that, these were going to be the things we designed our whole curriculum around. We did our research. So these are our actual core concepts, things we call them the core organizing pillars. And every course learning outcome and student learning outcome keeps these in mind. All right. So patient-centered care. So patient-centered care is focused on the patient or designee as a source of control in consideration of patient and family cultural preferences, beliefs, and values. As an advocate, the nurse provides timely, compassionate, and coordinated care. And that's really the focus of today's lecture. There are some other things in here too. We're going to be looking at safety and quality improvement, professional identity, teamwork and collaboration. That interdisciplinary communication is so important, and informatics and technology. And we also look at nursing judgment, our evidence-based practice. So these are in every syllabi for every course, so you should be well aware of what our core organizing concepts are. But understand where they came from. This was done through research, and they are derived from QSIN. Your HESI data, by the way, whenever you guys take a HESI exam, one of the reports that we receive from them is, as a whole, how are you achieving each of these? How well do you do in nursing judgment? How well do you do in professional identity? And we keep track of that to see how well you're accomplishing the goals. Okay, so providing patient-centered care. So the QSIN KSAs. Communication, compassion, culture, patient education, and empowerment. How are you going to implement a care plan and expect goals if the patient isn't part of the plan? Maybe your plan is the patient is going to do a certain activity, and the patient, you didn't consult with the patient, you didn't ask the patient, and the patient says no. Where does your plan go from there? Exactly nowhere. So you have to use you have to talk to your patient as part of the team. And you have to respect them, patients and families. You have to listen to their concerns. Their big concern may not be your big concern, and you have to communicate with them. All right? And we have to observe the ethical principles, right? And those are all from 1010: autonomy, beneficence, non-maleficence, fidelity, veracity, and social justice. So on the side in the orange box, you'll see there's an actual campaign for this to help patients be part of their own case management. And it's called Speak Up. So telling people, and they get information on this. Speak up if you have questions or concerns. So telling a family or a patient that you have the right to ask questions and to speak up. Pay attention to the care you get. There's so many people that don't understand their care plan, and that's our fault. We didn't do a great job at communicating with them. All right. Educate yourself about your illness. So patients should be encouraged or provided. So nowadays with Google, there's a lot of misinformation. So we should provide them with the correct information. And they need to learn about what's going on with their own body. Okay? They need to have someone they trust at their side. So a trusted family member or friend. Sometimes in the absence of those, the primary nurse becomes their advocate. And that's a huge role. Not everyone has somebody to take care of them. Here's a big one. Know what medicines you take and why you take them. How often have we given medications to someone and they have no idea what it's for? It's less and less common because, again, this is the age of the internet, and a lot of people now are Googling or reading documentation so they know what they're actually taking, but there's still some people out there that have no idea. Using a healthcare organization that has been carefully checked out. People are consumers now. They will look up, if they have to have a routine surgery, they will look up all of their area hospitals, look up reviews. They can look up patient indicators, readmission rates, things like that. And they're going to be a savvy consumer, all right? And to participate in all decisions about your treatment, they need to be part of the plan. People have the right to say no. They absolutely have the right to say no. So we also have the National Database of Nursing Quality Indicators, the NDNQI, all right? So history of evaluating nursing care quality. Now this began all the way back to, when Florence Nightingale identified nurses' role in healthcare quality. So she started using statistical methods to generate reports. And her big thing was the environment. So they had lots and lots of soldiers dying of infection and other diseases. They wouldn't die of the wound, but they'd die afterwards. And she correlated that to the environment, how clean it was. And she was the first person to really do that. So over the years, quality measurement in healthcare has evolved. And the workforce restructuring and redesign has demonstrated the need for the ANA to evaluate nurse staffing and identify linkages between nurse staffing and patient outcomes, right? If nurses are running the show and helping the patient understand what's going on with them and monitoring their progress and documenting and teaching and all the things that we do, then we needed the time to actually do that. If we're running from room to room and can only spare 5 minutes per patient, all the things that we need to accomplish to improve outcomes isn't going to happen. So they started looking at nursing staffing. So in 1998, the NDNQI was established by the American Nurses Association, so they could continue to collect all this data, right, and develop nursing's body of knowledge, all right, and they did take a look at nurse staffing and patient outcomes, and they continue collecting data, all right. And in 2015, Press Ganey acquired NDNQI. So it was so good that Press Ganey adopted it. So it's a really good initiative, all right? So we're evaluating and improving patient care. So they've made a lot of progress. So right now, the big issue is patient safety. So that's where the spotlight is. And public reporting. So all this stuff is public information. Okay, if they receive Medicare money, then all of this data is publicly reported. All right, so it increased the need for nursing to collect and monitor the data related to patient outcomes. And they really have shown that the less patients we have, the lower the nurse to patient ratio means better outcomes. Why? Because we're better able to do our job and maintain patient safety while they're in the hospital. Okay. And so what we're saying by validity and reliability, study after study after study, repeat after repeat after repeat, that nursing care improves patient outcomes, and it identifies the link between nurse staffing and patient outcomes at the unit level. So in the early, I guess it was the 1980s, they started replacing RNs with other members of they thought, well, we don't need as many RNs. A lot of the work they do could be done by a CNA. And guess what happened? They realized that, we've got more falls, we have more readmissions, we have more bad outcomes. And they realized that the nurse, you need the eyes of the nurse at that bedside level. You need increased nurse surveillance. You need the nurse to be able to see every patient understand what's going on, put the whole picture together. So they made that mistake, and then they realized that that was a big mistake. Sorry about that little interruption. Um, so other indicators are pediatric and psychiatric indicators, and those have been added because participating hospitals like Butler have requested things that are more specific to their area of practice. And then they've added things to the database over time that were of interest nationally. And it's a multi-step process. All of these things are done by nursing research, done at a unit level or sometimes at a hospital level, and it's all outcome focused. So if they implement something, they have to study it, make sure that it's evidence-based. Is it something that we need to track at a national level? And that's what I mean by pilot testing. So it's evaluating the evidence that a specified indicator is nurse sensitive. Is this in control of the nurse? And does it mean that nurses, the ratios or nurse involvement, does that affect patient outcomes? So then they pilot test. So if there's a nurse-driven initiative for prevention of catheter-associated UTIs or CAUTIs, then a nurse-driven protocol would be pilot tested at a participating facility, and then if it works there, they would broaden the search. And then pretty soon, that may become a national recommendation. Okay. Ventilator-associated pneumonia, central line catheter-associated bloodstream infections, VAP, and ventilator-associated events. Okay. All of these things are tracked, okay? Processes and outcomes are tracked, okay? And then we also send out a questionnaire to patients. All right. So discharge planning starts at admission. So we have to complete a thorough admission assessment, ADLs and IDLs prior to admission, the living situation and their social history, their full health history and medication list, and it's not a little like quick questionnaire. Now, if you have a 25-year-old that came in for appendicitis, you still have to ask all those questions. Did you use any assistive devices at home? Do you eat a regular diet? Are you able to do your own shopping? People skip over this stuff, and they don't realize that they're skipping in a very important part of the admission. All right? Living situation and social history. That 25-year-old may be homeless, and unless you ask, then you're not going to know. You can't assume anything. You have to ask every question. Yes, it is time consuming. Yes, it feels repetitive, but you must ask. A full health history. Ask every question. So a lot of adults, and I've seen this happen, is you ask them, do you have any, health history or diseases or anything we need to know about? No, I'm pretty healthy. Then you start going through the list. Have you ever had this? Have you ever had that? Have you ever had a surgery? And they go, oh yeah, I had elbow surgery when I was 15. All of those things need to be documented. That means they've had general anesthesia before. That may mean they have an implantable device. We have to investigate those things. All patient goals should be discussed with the patient, right? And what are her personal goals and questions? Well, she's worried about, will I be able to stay in my house? She was living independently before she came in. Who's going to take care of my dog, right? She walks her dog every day at the park, and she lives alone with her dog. Who's going to take care of the dog? And will Medicare pay for everything? This is such a huge concern for our older population. Will Medicare pay for everything? Not necessarily. All right. So normally I would have you guys do group work, and so I want you to think about this before we continue the video, okay? So planning discharge for Mrs. M. So within your groups, discuss the discharge needs for a patient requiring hip replacement surgery. So do this on your own. Based on the limited information you have, do you think she'll be able to go home straight from the hospital? Why or why not? How long does a patient stay in the hospital on average following hip replacement surgery? And what are the complications that occur following this type of surgery? And how do we prevent those from occurring? Okay, so if you thought about it, you probably have a lot of things that we're going to be looking at with Mrs. M, right? This isn't a simple case. It looks simple on paper, and then you go and you have to think about this is an 80-year-old person. She has hypertension. She lives alone. She has a dog to care for, and we don't even know yet, why she fell, right? We're not 100% sure why she fell. Is she going to be able to go home and take care of her dog? Is she going to be able to take care of herself? Does she have stairs? Does she have an accessible shower that she's going to be able to climb over? So that's a lot of, that's a lot of things that we have to worry about. So showering, climbing the stairs, grocery shopping, or does she drive? Does she still have her license? Is she going to be able to drive following surgery? So the short list of complications, we definitely have risk for falls, right? She's going to have altered mobility with a new hip, but she's not going to be as spry as she was. So using the correct equipment, is she going to have a walker for a little while? Probably. We're going to have to collaborate with physical therapy, occupational therapy, the CNAs, lots of patient education is going to have to happen. She has a risk for a hospital-acquired infection, right? So she had surgery, which means she most likely had a catheter placed at some point, and they usually remove that as soon as possible. Even with a patient who may not be getting up immediately, we will take the catheter out. They would rather, believe it or not, use a bedpan than keep a catheter in. It's not for convenience. In the old days, they'd be like, oh, well, we'll keep it in for convenience overnight so that she doesn't have to get up the first day. No, as soon as she's able to get up, she's going to get up. Even if it means standing her on her good leg, pivoting her, sitting her on a commode, we're going to do that because it's way less risk than having her have a catheter-associated UTI. And remember, this is something that gets tracked nationally. Our number of catheter-associated UTIs is now publicly reported. People look this stuff up. Okay. It can also affect Medicare reimbursement. So we are responsible for that. We're going to have to, make sure everyone's doing their hand washing to prevent surgical site infections. Other things would be aseptic technique for wound care and her IV. We don't want to have an infection from an IV. We don't want to have an infection at the wound site. In surgery itself, one of the measures that the prevention of surgical site infection, one of them is delivery of an antibiotic within 30 minutes to an hour before, so we want to have them get IV antibiotics before surgery. So the reason for that is they want the maximum amount of the antibiotics circulating when they make the first cut. They also want to keep the patient normothermic in the surgical suite. Yes, the ORs are kept cold, but we don't want the patient to get cold. When you get cold, your perfusion in your extremities isn't as good because the body, reserves the warmth for the core. And if we don't have great perfusion in the extremities, that also means we don't have good infection surveillance, right? Remember that. Perfusion also equals protection. So if they're really cold and the limbs are cold, especially her hip, that increases the risk for a surgical site infection. All right. Her fluid status and nutrition. This patient has hypertension. We could end up accidentally fluid overloading her if we're not careful. Complications from immobility. We're going to be dealing with DVT, PE, pressure ulcers, pneumonia, constipation, etc., etc. So the goals for her would be early mobility. All right, so as soon as she's able to, we can stand and pivot her, and depending on the surgical procedure and what the surgeon's orders are, she may be partial weight bearing even the first day. She may be total weight. It really depends on the device, what the surgeon did, and we get them up right away. And that DVT prophylaxis, she may receive Lovenox or sub-Q heparin. Incentive spirometry teaching. all of those things we're going to be worried about. Then we have our medication complications, right, from opiate pain management. And yes, usually they usually get an opiate in the OR as part of their sedation. So most patients receive some form of an opiate. And then we're going to be dealing with the risks of opiates. So hypotension, respiratory depression, constipation. We make sure we do a good medication reconciliation for her. And then psychosocial risk for depression. This was a lady that went out every day for a walk with her dog. I know it sounds weird, but the isolation from her dog could actually, affect her a little bit. The social isolation of being home. And we need to make sure that we follow her wishes in her care and have her speak up. And we want to involve her family. All right. So I've had two, not hip replacements, that I've had two older family members that have needed knee replacements very recently. And they had different experiences. So, and it really was part of the case management and individualized patient-centered care that made the difference for both of them. One was had a high level of functioning, lived with family, did very, very well, and was able to go home directly from the hospital following her knee replacement, even though she was in her 70s. And this is because she was able to follow directions, did very well with her PT, and was able to have PT come to her home each day. The other family member needed to go to acute rehab following her hospital stay. Was still doing well, but lived at home alone and had some, other, health issues that could become complicated. So she needed skilled nursing. There isn't a rubber stamp. It isn't because you had a hip replacement that you're going to go to acute rehab. There are some instances where patients are doing so well and have so much home support that they're able to do the rehab in their home. All right. That's not as common, but and then there are people that need maybe a week or two or maybe longer in acute rehab to maximize functioning, especially if they live home alone. All right. So an important member of this team is the RN case manager. They perform utilization management and discharge planning. So the minute they hit the hospital, case manager in an acute care and in long-term care, they're going to, how do we get this person optimized for discharge, right? So they do an admission assessment. They provide payers with a clinical summary of the case. That means provides insurance companies or Medicare the reason for their admission and what the plan is. And then they discuss the case with payers. So is this patient going to be inpatient or observation? It's very different. They will respond to any daily clinical denials received from payers. So sometimes the payer or insurance company is going to say, no, that's not appropriate. And then the case manager has to confer with the team and communicate back with the payer and let them know, yes, this is here's some more information for you to make your clinical decision. All right. And they want to perform concurrent reviews for repairs to justify patient days in the hospital. So the payer may say, well, for a hip replacement, we're only going to cover, I'm going to make this up because I really don't know what it is for a hip, but 2 days inpatient. Okay. And let's say there's a complication. Maybe the patient develops a DVT. The case manager actually communicates and lets them know to justify. They have to justify how many days they're in the hospital. All right. So just because the patient's like, I don't want to go home, that's not justification in terms of an insurance company. They need to know is there a real reason, like a hard fact, medically necessary? And the RN case manager will convert the patient. So if they get admitted to the hospital, they may be admitted just for observation. We don't know what's going on yet. And then once it becomes clear that the patient's going to need to stay more than 24 hours, they convert them into from observation to inpatient. And it is based on clinical case. So that's the case manager's job to do. And then they work with the appeals coordinators if we have to appeal insurance payments so that we get paid, the hospital gets paid, or that the patient doesn't end up with a huge bill. So discharge, disposition, and planning, again, starts right at the admission time. and we need to evaluate for any discharge planning needs. It takes a couple, it's not an instantaneous thing. We have this patient that comes in who lives alone, broken hip, needs a hip replacement. That is more complicated than my 25-year-old who's independent and lives with family and comes in for an appendectomy. Very different. We're anticipating the need for at least some acute rehab, correct? So that starts that day, because you can't just go ring-a-ding-ding and instantly get a placement somewhere. Sometimes it takes a few days. Sometimes you have to call multiple facilities. You have to make sure their insurance is going to cover it. And other things that they may need. Durable medical equipment. Are they going to need a walker, a cane, a specialty bed, oxygen? Are they going to need visiting nurses if they're not going to an acute rehab? Are they going to need short-term rehabilitation? Are they going to need a long-term acute care hospital? That's for someone with a very complicated, think of someone who experienced a severe burn and is going to need long-term. They're not going to stay in an acute hospital very long. They're going to go to a long-term acute care hospital or home with visiting nurse services. If they have a simple wound that needs dressing changes every day, that's not a reason for them to stay in the hospital. That's something that a visiting nurse can come out and help assist them with, and hopefully transition them into doing their own dressing changes through daily teaching. Patients have rights, okay? Now, we say that patients have rights. So patients are offered a choice of different agencies. This is also contingent, though, on their insurance company, right? So their insurance company may say, we'll only pay for this place or this place. Or if they have Medicare, they'll be given probably a short list of places. And then we have to check to see if those places have an opening for them, right? If they are a person of means, if they have money and they're private pay, then it's their right to choose wherever they want to go that fits the right type of rehab. The RN case manager will go in and interview them, talk to their insurance company, do a complete assessment, and then, what is the patient like at baseline, all right? And they come up with a safe discharge plan or transfer of care, right? Like the person in my family who was able to go home right from the hospital after a knee replacement, that was a safe discharge. They had visiting nurses. They had visiting physical therapy and occupational therapy coming to the house. For my other family member, a transfer of care. She needed to go to a acute rehab for her rehabilitation. So that's what a transfer of care is. So it's determined based on her living at home with her dog that she'll need a transfer of care, right? So Mrs. M wishes to remain as independent as possible despite having 3 grown children who live nearby. And her goal is to return to her own home as soon as possible. So the hospital team, which is led by the physician, the RN case manager, have determined that she needs some post-acute care services, right? So after hospital. All right. So here's something specific to Rhode Island. And you'll hear it called a page 5. It's called a page 5. And it's a transfer of care form, and it has to be filled out between healthcare facilities and home services. All right, and it's time consuming. And the Lifespan Systems in Epic, I believe it's still done electronically. At Care New England, it's a physical paper page 5. It is time consuming, but you have to fill it out as completely as possible, and it asks a lot of stuff, right? The diagnosis, surgery, allergies, active infections, what the treatment orders are. Are they going to skilled home nursing care, physical therapy, occupational therapy? Are there new prescriptions? All the medications to be taken after they discharge. And then they decide what the patient is or is not allowed to do. Can they go to a gym class? Can they resume sexual activity? And then the physician needs to sign that. Okay, so the whole plan of care needs to be outlined on this form. So now we're going to talk about post-acute care services. So, inpatient rehabilitation facilities, all of these we're talking about skilled nursing. So nurses are part of the plan. This isn't just, a rest home. This involves active hours and active goal attainment. So a skilled nursing facility, it's usually temporary in nature and it's focused on rehab, and that's intended to prepare them to return home to their independent way of living. We have the long-term acute care hospitals. So it's an extension of an acute short-term hospital stay. So it provides many of the same services, ventilator or trach, collar weans, multiple traumas, skeletal traction, and it's for people who need extended care for more than 25 days. In the community, we have home care, right? So my family member was able to have daily visits by nursing, PT, and OT. And the first week it was every day, and then they spread it out as she got better. Support services, so a CNA for AM and PM care, for instance. Outpatient rehab, that's where the patient travels to their appointments or PT. So after the first few weeks from my family member with the knee replacement, she was immediately discharged to home. She had home services for a little bit, and once she was walking around pretty well, she would have appointments at the outpatient rehab, and she would go for her appointment, work with her therapist, and then come home. Assisted living. So an assisted living is sort of like an apartment with some additional services. So there are people who are mostly independent. There are assisted livings with rehab attached to them, or rehab floors. So my other family member who needed to go to acute rehab, she was already living in an assisted living, and there was a rehab floor. So her apartment was upstairs, and for a couple of weeks she lived on the other floor, which was just for skilled nursing and acute rehab. Same building. She was in a different room for a short period of time where she could be managed by nursing. And then once she was walking around and doing well, she was discharged from the acute rehab and sent back to her assisted living, where she then participated in outpatient rehab. So she would, go down for breakfast, and then at certain periods during the week, she would go to the rehab floor and work with her occupational and physical therapist. It was fabulous. She didn't have to travel other than taking the elevator, and she was in her home and with her friends, and she had a good time. Long-term care or a nursing home is a resident, this is where you go to lives full-time at a facility that has 24-hour nursing care. And that's usually a permanent placement, right? We're not talking acute, we're talking long-term. Patient with advanced Alzheimer's that needs to have skilled, that's beyond the capability of the family, that needs to be cared for in a safe place, and is probably going to stay there until, the end. That's what long-term care is. So home care considerations. Now, when they're in an acute rehab or a long-term acute care, they have to the facility and the nursing staff and they have to justify the need for that facility, right? You have to show that it would be detrimental to the patient to go home. Like, you have to show that they need to be there. It's expensive. Sometimes they offer something called a leave of absence visit. Now, this is very strict. This has to be approved. This isn't like, oh, I feel like going out to lunch. Okay, some reasons you could have a leave of absence visit include like a religious service, okay, or a holiday meal with family. Like, you had your knee replacement a month ago and now it's Christmas Day, and they allow you with permission, and there's a lot of red tape involved, to go home for an hour to have a meal with your family, and then you go right back, okay? Or it can be to visit a new facility. So let's say Mrs. M decides to move into an assisted living following her rehab. This would allow her to leave very short term to go view the property and then come back to finish up the rest of her rehab. So it's a short visit, short visit. It has to be documented. And then they also do something called a pre-discharge assessment. So if you're going home, are the bathrooms accessible? Are there stairs? Does the patient need additional equipment? Do they need a built-up toilet seat? Now we know that Mrs. M had a hip replacement. We know she's probably going to need a built-up toilet seat. So who's going to put that in? Is she going to crawl on the floor and use a screwdriver, or how is that going to happen? Are there throw rugs? Is the environment safe? Does the bedroom have room for the patient transfers if she has to use a wheelchair for any reason, or a walker? Does the patient have transportation? So we do have the RIDE program within the state, but is there a family member, or is she going to be able to progress to the point where she drives? And is she psychologically prepared to go home? All right. So when they're in a long-term care, and any type of post-acute care, there's a minimum data set, and it's required. I mean, required. Minimum data set. It's required by Medicare and Medicaid. So there are assessments that have to be performed on a regular basis. Okay? Have to. If they want to get reimbursed, they have to fill these out. Hearing, speech, vision, cognitive patterns, mood, behavior, preferences for customary routines and activities, functional status, bowel and bladder, etc., etc., etc. Okay? These are minimum data sets. They have to be assessed if they want to be reimbursed by Medicare and Medicaid. Guess who gets to fill out most of this stuff? It's the nurse. So there are forms or electronic, it's usually done electronically nowadays, that they have to fill all of these out on a regular basis. All right. So following her short stay, right, in a rehab facility, she is transitioned to home with home services. Yay! Before discharge, they do allow her a leave of absence visit is performed in her home, so that her home can be evaluated for safety. So they bring her home, and working with PTOT, they evaluate her home. Is she going to be able to get in the shower? Is she going to be able to maneuver in her bedroom? How well is she able to handle the stairs? Okay. And she also receives education to prevent the need for a readmission to the hospital. Readmissions to an acute care hospital within 30 days are a big deal, okay? We're supposed to help prevent that from happening. Some things are, unavoidable, like, she got robbed or something. That's unpreventable. But if it's related to the original illness and it was something seen as preventable, then that could mean that we may not get reimbursed for the readmission, the hospital, all right? So a lot of the discharge includes education, when to call the doctor, making sure she follows up with all of her appointments, having, family in place to give her rides or a ride service. She's going to need to continue to go to rehab after she goes home. Once her home visits are completed, she's going to need to continue to go to rehab. How is that going to happen? So here's the high cost of readmissions. And this is an old, so readmission is a person who has been readmitted to the same or another hospital within 30 days of hospital discharge. All right. So this costs $40 billion, right? $40 billion. All right. It's a huge deal. A hospital readmission gets flagged, okay? Case management really has to take a look at why this patient got readmitted. Was it preventable? Did we not have the right services in place for this person? Did we make a mistake with our patient education? Were they given the wrong medication information? It needs to be scrutinized and the reason why is that money on the side, $40 billion. And also the fact that we didn't do a great job and we didn't keep this person out of the hospital. So transitions of care, okay? Ineffective care transition processes lead to adverse events and higher hospital readmission rates and costs, right? this usually happens when people go from one facility to another or they go home. A lot of communication breakdowns. So care providers don't always communicate well. Okay. That's why that page 5 for the Rhode Island transfer care, that's why it's so important. Okay. And there's a YouTube video I'd like you to watch. So take a few minutes and make sure you watch this YouTube video. So preventing readmissions. How do we prevent people from having to come back to the hospital? So this is staggering, right? Almost 1 in 5 elderly patients return within 30 days of leaving an acute care hospital. 3/4 of chronically ill patients wouldn't need a return trip if they had a plan for follow-up care. Meaning we didn't do our job. 1/3 can't explain their own medications. They don't know what they're taking them for. This is current, by the way. And 1/2 can't state their diagnoses. They can't tell you what they have. So how to avoid going back to the hospital, right? So this is what we teach patients how to advocate for themselves. Get a discharge plan and bring it to all follow-up appointments. So all those printouts you hand to patients, if they're chronically ill, they should have a binder for all of these, for every visit, so that a new provider, if brought in for a special reason, can go through all of them and see their course of treatment. Their scheduled follow-up appointments. So making it clear and helping them make their follow-up appointments. So if they need 3 follow-ups with the doctor after surgery, we should make sure that those visits are made before they leave. A list of all their health conditions and allergies. If they use a regular pharmacy to pick up their prescriptions, do them a favor and write the phone number down or have it printed on their discharge so they can call the pharmacy or they can call the doctor's office. Make sure they have the contact information and their phone numbers. New equipment. Make sure they have that plan in place, and patients should speak up. I'm going to be using a wheelchair at home. How am I getting a wheelchair? The medication list should be brought with them to all appointments. So that binder with all their medications listed is important. How often have you seen a nurse get frustrated because you're admitting someone to the hospital or any kind of facility or an outpatient clinic and the patient doesn't know what they take at home? That's getting easier now because now pharmacies communicate with hospitals. So they can see, for instance, at CVS, they can get a list directly from CVS. But then the nurse still has to make sure that is the patient still taking the medication as prescribed or did they stop it? All right. And that includes vitamins and over-the-counter medicines. When they should take it, how much and for how long, all the possible side effects. And if they have a new medication, what med does that replace? Okay. And at the bottom here are the big points. Asking questions about unclear instructions. This happens all the time. I have patients in an acute care hospital, and the doctor and the rest of the team come in and they explain a whole bunch of stuff. And then the patient turns to me and after they leave and said, what exactly did that mean? And the reason is they're afraid of that white coat. They're afraid to look stupid or they're afraid to ask questions to the doctor, but they feel more comfortable with the nurse. So it's our job to explain to the patient. If it's something that's really important, like a surgical consent, we need to feel free to call that physician back in the room and say, look, she just asked me some questions. Obviously, she needs more information from you. Okay? Having someone repeat those instructions back to you in their own words. So ask the patient, do you understand what's going on? Can you tell me in your own words what you think is happening? All right? Have a family member or caregiver there. Whenever I'm discharging someone, I ask who's coming to pick you up, and if they're going to be there, I ask if it's all right if I go over the instructions with that other person, because the person who's sick may be thinking about one thing and not the other areas that I want to stress with them. So having a family member or caregiver in the room is important. Knowing the danger signs and what to do. So every patient I discharge from an acute care hospital, if you have chest pain or shortness of breath, you're going to call 911. If you have, mild symptoms, I explain, you should call the office. If it's severe symptoms and it's after hours, go to our emergency department, or call 911 if you're alone. Okay? Asking your doctors for information on their health condition, right? So they can figure out how to stay healthy. All right. And then if you leave the hospital and you're cared for by a hospitalist, someone in the hospital, the doctors there care for you, you need to schedule a follow-up with your own doctor within 2 weeks. Your primary doctor, you need to see them. So they know what's going on. So they're not still prescribing you something that may be detrimental to your health. And also, your primary doctor, just like your primary nurse, helps organize the rest of your health care. They need to be informed and do an exam and see how you're doing. Okay? Because if you have surgery on your ankle, that's all well and good, but your primary doctor is going to be concerned about your other pre-existing conditions. The surgeon's going to look at your ankle, right? Your primary doctor is going to make sure if you're diabetic, how is this affecting your diabetes? If you have a heart condition, how? So your primary doctor is an important member of that team. So here's another group work. So I normally would have given you some time to do this. An ounce of prevention is worth a pound of cure. That's from Benjamin Franklin. So Mrs. M is actually an example of a 30-day readmission. Surprise! So 2 weeks before her hip fracture, she was briefly hospitalized for bradycardia related to a beta blocker she was prescribed to treat her hypertension. During her stay, her prescription was changed to Hyzar, which is the losartan and hydrochlorothiazide combo. On the morning of her fall, she realized she had forgotten to take her medication the day before, so she took an extra pill to catch up. What could have been done to prevent this? What did we do wrong? How did we cause this? Okay, so I wanted you to actually think about the slide before. What did we do wrong? What happened? Obviously, someone dropped the ball with patient education and medication reconciliation and explaining to her that you do not double up on that medication if you forgot a dose. If you forgot a dose, you forgot a dose. Just take the next dose the next day. Okay? Why? Well, the reason for her fall is she probably had low blood pressure, and that contributed to her fall. So in a way, ineffective teaching at her prior discharge caused her to fall and break her hip. She is a 30-day readmission. Okay? Now, she's a simple case of an uncomplicated hip fracture that needed hip replacement. During the semester, we're going to be talking about patients with catastrophic illnesses, all right, and different trajectories than a hip fracture, okay? What would we do if, in addition to her hip fracture, she experienced a catheter-associated UTI, or had developed a pressure ulcer, or a DVT-PE, or unfortunately had experienced an acute cardiac event, or she had experienced a stroke, all of which are risks from being in the hospital, all right? Normally, I would have you work in a group and give you some time, and I would have you work all of this out. What would have happened, all right? How would this trajectory have been different with all of these? Okay. So, let's go. So, if she had had a UTI that was caused by a catheter, guess who's responsible for a patient that gets a catheter-associated UTI? Is Medicare going to pay for that? Probably not. Because that's something that we're supposed to be vigilant about, preventing. If we didn't do a very good job at managing and preventing things like DVT, if we didn't demonstrate that she was using SCDs or that she was getting a prophylaxis like Lovenox and she developed a DVT in a hospital, that could be considered a cost that the hospital would have to eat, so to speak. Okay. And think about the longer hospital stay, the risk for bleeding, because if she developed a DVT, she's going to end up needing heparin therapy or Lovenox therapy. She has a fresh surgical wound and could increase her risk of developing bleeding postoperatively. Okay. You see where I'm going with this. A lot of stuff's preventable. And if we didn't prevent it from happening, then the hospital is going to be responsible for paying for that. It's going to complicate her recovery, keep her in the hospital longer, and increase the likelihood that she's going to be in rehab a lot longer. Okay. So, nursing interventions for the new nurse, you guys, to prevent readmissions. Don't skip questions in the admission assessment. Have to ask. I can't tell you how many times I've watched people skip through this. Like, yep. A thorough medication reconciliation. Really. That includes all the over-the-counter stuff. Oh, yeah, I use, St. John's wort for mood elevation. That's important information you should ask. Do you take any herbal supplements or vitamins? I had a patient that was taking lots and lots and lots of vitamin D. And, vitamin D is great, but if you overdose on that, it can actually cause parathyroid, a decrease in parathyroid issues, function, and it can lead to calcium problems. Take the time needed to perform patient education, and then use all the available resources on your unit. Don't just hand them a stack of discharge papers and ask them if they read it. Go over the paperwork. If they're a visual learner, see if there's a video. A lot of places have DVDs and DVD players, and you can get a computer in the room and play a YouTube video. It doesn't matter. If they're a visual learner, they need some kind of visual stimulation. See if the family is available to come in and learn about this at the same time. Speak with the case manager and the doctor if you have any concerns about patients scheduled for discharge. One of the best students I've ever had was in Nursing 1020. And this was in the old program, so they had a little extra clinical time. But she was a non-traditional student, meaning she was a little bit older, had kids of her own, so forth. And we were at Memorial while it was still open, and realized that the patient that she was taking care of was scheduled to be discharged. And she asked questions because she had the time to do so. And she learned, well, not only did he live alone, which the case manager knew, but when he had fallen at home, he had bled and broken some glass, and no one was at home to clean all of that up. So he was going to need someone before he got home to clean all this broken glass and blood and all that out of his kitchen. And so she took it upon herself. She talked to case management, and they figured out a way for the landlord to come in and have someone clean up his house. He would have just been dropped off at home or given a ride home, and he was in no position to do that kind of work. All right. So that was a great student story. And she made phone calls herself. She called the landlord. It was a fabulous process. Okay. So making sure you talk with them, saying, I'm telling you, I don't think she's going to be able to manage herself at home. She lives by herself. Her kids all live out of state. What are we going to do to prevent hospital readmission?